We know we now have 3 neurotoxins in our marketplace, and how do the panel members feel that these currently approved neurotoxins differ, if you do feel there's any difference?
They definitely have different characteristics. I do primarily Botox. I think it's somewhat out of habit. I did it for so long that I feel like it's like my violin, that I just know how to play it really well. And I do use Dysport when I like it around the eyes because it does give you a little bit more spread and a little bit more frozen. And there I think it's okay unless somebody has really large orbicularis or oculi muscle inferiorly, because if it's really frozen, then sometimes it will become more prominent. But I don't like it really in the forehead because people want to look natural, and then it really freezes their forehead. So I use Dysport when people stop doing well with Botox, if the Botox stops working as long. So I've had some people who've done well with Dysport, and then I've had some people who didn't do well with Botox or Dysport, and so we used Xeomin, and we were successful with that. So there's probably some immunological, reaction to the proteins, is my thought.
I like them all. Again, I don't think it's the product. It's how the painter's using that product on the patient's face. And with Xeomin, my experience has been that maybe it takes a little bit more than the 1-to-1 unit dose that they recommend. There's big talk about the ratio of Dysport to Botox, 1 to 2.5 or 1 to 3. Again, I don't put a lot of stock in that. I think the more you use the product, you get a feel for your patients, and it's different. I don't know that there's an exact number.
I'm a data-driven, evidence-based kind of guy. Let's talk just quickly about the 3 toxins and the data behind them. I think that you can, in most cases, use all 3 products interchangeably. Dysport, I think, would be the most different of all 3 in terms of the dose that's required. As you require more units, there does tend to be more spread of effect. So patients and physicians will talk about this sort of stronger freeze that you get with Dysport, particularly if you're using it in the crow's feet or in the frontalis. I think it diffuses a bit more, and patients will note this sort of more global freeze, if you will. Doesn't mean it's a bad product. Sometimes that's what you want. So I think that is one difference. Now, when it comes to Xeomin and Botox Cosmetic, I think that there is enough in the literature right now, in the blepharospasm, the cervical dystonia, and the cosmetic literature, to suggest that they are pretty equivalent in their clinical response, particularly in the cosmetic arena. If you look at the really nice paper by Sattler, Carruthers, and Flynn, using 24 units in the glabella, the efficacy curves and the extinction curves are laying right on top of each other. There's been a lot of argument that, well, this was a 24-unit study, not a 20-unit study. So this has been going back and forth now for a couple of years. I think it's highly likely that we'll see a 20-unit glabella study, Xeomin versus Botox, within the next couple of years. There is this sort of persistent signal out there among users that Xeomin may be a bit softer. Whether that's true or not, I honestly do not know. I think we need better studies to sort of pick that up.
I carry and use all 3 toxins that are on the market. And rather than just talk about these, let's talk about the future. In a year we'll probably have 4 toxins. In a couple of years we'll probably have 5 or 6. We may even have a topical toxin. Same thing with the fillers. We're going to have a lot of different fillers besides injectable fillers. We may have solid-state HA threads that you can thread through the skin. I think as we get a bunch of different HA fillers, we will see that they are more and more disparate. We'll have very soft fillers, very stiff, very thick fillers, and they're easily differentiated once you inject one person with them. But I think when you look at all the toxins, even when we have 7 or 8, we will start to realize how similar they are. Not identical, they're not exactly the same, but they will be very, very similar. And the reason is dissociation. at physiologic pH, the complexing proteins fall away. There's even evidence to suggest in the Iselli paper that as soon as you reconstitute these toxins, a great deal, if not a lot, if not total, dissociation happens right in the vial. That's a little controversial, but I think as you get ease of use with all the different toxins, you realize how close they are, not identical, but very, very similar.
Okay, I have all the products in my office as well. I think that initially, when we started using Xeomin and it came to our house, we didn't understand the swirl. And now, so some of the patients when I started with Xeomin in my practice didn't think it was as good, didn't think it lasted as long. I think I didn't give them as many units. I didn't realize it because we were swirling, but we weren't inverting the bottle to make sure that we were getting everything off that rubber stopper and in the cap. And I just think we probably were leaving a lot of units in the bottle, not understanding that part of the reconstitution of this product particularly. So once we started doing that, I have found just in my own hands, they're all three very comparable and I like to use them. I think some of the points I totally agree with around the crow's feet. I do like the Dysport. I think that patients come into my practice and say, look, I'd like to try this new one. Okay, we've got it. And so I think that we have to be on that cutting edge and have those things available for our patients. I think that I've used less units, regardless of which product it is, in many locations. I mean, I used to use a lot of neurotoxin in the forehead, and now I use very little neurotoxin in the forehead, especially in my older patients that need that frontalis. So I do believe we've learned that, as Michael's pointed out, they're probably more similar than they are different, and that I've learned to feather whichever product it is more than I used to. I use micro droplet technique in areas that I never used to do that, even periorbitally around the eye. I think that less is better many times with these neuromodulators than we used to think. So it's an evolution that we're going through with understanding products, with understanding how we use these products. One thing I do like in my office is we reconstitute the products all so that in terms of units, it's volume. So 0.4 in a syringe of one product I can use interchangeably. So whether they put down Dysport, Xeomin, or Botox, and it's a 0.4, I know I can utilize that volume the same, interchangeably. So I don't have to worry that we've mixed up something and I don't know what it is.